Hello everyone, welcome to the first episode of High Yield Pathology series by PathoGeeks. This is Dr. K. Shravani. We're starting with amyloidosis today. So what is amyloidosis? All of you must have answered in your minds that it is an accumulation of abnormal protein. And here in the background, you can see the same, where it is accumulated as an amorphous pinkish material or amorphous eosinophilic material. So what are these abnormal proteins? These are misfolded proteins, which are extracellularly accumulated as insoluble fibrils. As they're insoluble, they're accumulated. These amyloid proteins have some common characteristics. Like this amyloid protein can be derived from any type of protein, but all of the amyloids share some common characteristics in its structure, which on electron microscopy can be seen as a continuous non-branching fibril of diameter 7 to 10 nanometers. So it can be any length long, but the diameter is only 7 to 10 nanometers. And on X-ray crystallography, we can see its beta pleated sheet configuration. This amyloid, whichever has been accumulated, can be visualized by a special stain known as Congo red, and it's Congo red positive. And now this stained Congo red stain slide, when seen under a fluorescent microscope, gives apple green birefringence. And this birefringence is due to beta pleated sheets. So here is a image of a glomulus showing an deposition which is reddish, and this is a Congo red positive. And the same thing when seen under fluorescent microscopy, you can see the birefringence. Coming to the pathogenesis, this can be due to accumulation of normal proteins which are produced abnormally, and can be accumulation of mutant proteins. The normal proteins are of two main common types. One is the AL protein or the amyloid light chain protein. So it is an immunoglobulin derivative. So it's also known as an immunoglobulin light chain protein, which are produced by B cells. B cells, specifically the plasma cells. Next is the AA protein. AA means amyloid associated. This protein is formed from a precursor protein known as serum amyloid associated protein, which is produced by the liver in response to chronic inflammation, where the mediators like IL-1 and IL-6 tell or stimulate the liver to produce this SAA. And both these proteins, they are normal, but they are not proteolyzed effectively. So there is limited proteolysis and therefore the accumulation. Coming to the mutant proteins, these are mutant and therefore can be easily misfolded, and they take in this configuration of beta pleated sheets. The most common one is ATTR or amyloid transthyretin. Next, let's learn about the classification of amyloidosis. It can be classified into systemic and localized amyloidosis. Systemic amyloidosis can also be known as generalized amyloidosis. Now, the systemic amyloidosis can be further divided into primary and secondary. Primary amyloidosis is when there is a deposition of AL protein or amyloid light chain protein usually in cases of multiple myeloma. Okay. So what is it? This is a excess production of immunoglobulin light chain. And this can be detected in urine as proteinuria. And these proteins are Benz-Jones proteins. Yes, you all know this. Next is the secondary amyloidosis, which has different types. Let's see reactive secondary amyloidosis. So we're saying reactive. It's reacting to some. It is an immune reaction. Okay, and here there is a production of amyloid associated protein. Okay, this reaction can occur in the background of chronic inflammation, where we've already seen the macrophages getting activated and then releasing interleukins, which cause liver to produce SAA, which is not proteolyzed, and AA or amyloid associated protein gets accumulated. So chronic inflammatory diseases, which is associated with most commonly are rheumatoid arthritis, inflammatory bowel disease, can be associated with chronic infections like TB, also can be associated with ankylosing spondylitis. Also this reactive secondary amyloidosis can occur in background of solid tumors like renal cell carcinoma and Hodgkin's lymphoma. Next is the heredofamilial amyloidosis. These are of two main types. First is the familial Mediterranean fever. So when you're talking about fever, so this also is there's some kind of interleukins which are released. So this also has an amyloid associated protein accumulation. So a little more detail about this familial Mediterranean fever. This is an autosomal down. This is a autosomal recessive condition with defects in the pyrin gene, causing increased interleukin-1, hence the fever, right? This interleukin-1, you know the pathway from here. And the other one is a familial amyloidotic polyneuropathy, in which we have mutated ATTR, which we have seen. So there is deposition of this amyloid in the peripheral and autonomic nerves, leading to this condition. We told familial Mediterranean fever is autosomal recessive, and this is autosomal dominant. The next one, another one, common one, asked is hemodialysis associated. So hemodialysis doesn't efficiently remove these beta-2 microglobulin from the blood. So this gets accumulated and forms this amyloid beta-2 microglobulin. And this is usually accumulated in joints, muscles, and tendon. And clinically, most common presentation of this patient would be carpal tunnel syndrome. The next is a localized amyloidosis, seen in, you can see in skin, lung, larynx, tongue, eye. This can be diffuse and nodular, and these are usually having AL protein. As microscopically in these localized amyloidosis cases, we can see infiltrates of plasma cells around it. So if plasma cells are around, they're releasing immunoglobulin, that is AL protein, amyloid light chain protein. Another localized amyloidosis I want you to remember would be in the CNS, that is the cerebral cortex, causing Alzheimer's disease. It's a kind of a cortical dementia where there is amyloid beta protein accumulation in the cortical neurons. Other few important points we need to remember is senile amyloidosis. Here, we have accumulation of unmutated amyloid transthyretin protein. And this usually occurs in the heart. Where in the heart? The myocardium of the heart. So therefore, the senile amyloidosis was also called as cardiac amyloidosis. The most common organ affected by amyloidosis is in kidney. And the deposits can be in the glomeruli, the interstitial peritubular tissue, or can be in the arterioles or arteries. Initially, when there is amyloid deposition in the kidney initially increases in size. But with the severe increased deposition and with progression of the disease, it shrinks. So why does this happen? This is because of accumulation of amyloid in the arterioles, slowly causing decreased blood flow and also giving the kidney the time to adapt. It's not like a sudden ischemia, but slow, gradual decrease of the blood flow, where the kidney adapts and it shrinks. There is atrophy. There is shrinkage. And also, there are two morphological, or you say gross patterns of amyloidosis in spleen, which you have to remember. One is sago-spleen and Lardacious spleen. So we call it sago-spleen because you have this sago-grain type nodules on the surface of the spleen. So why the same spleen with two different presentations? It's because, from histology, the spleen has sinuses and follicles. So when there is amyloid deposition in follicles, it gives an appearance like this. And we have something called sago-spleen. And when it's in the sinuses, the spleen is excessively enlarged, and we call it as a Lardacious spleen. So that's all for the video today. We have a interesting question. Amyloid deposition is seen in all of the above malignancies except. Do post your answers in the comments.